Awesome. So thank you. Rihanna Schmidt is here from Hope Canyon Counseling. She has been involved in maternal mental health for several years, and I'm going to stop my share here and let her tell you about what she does.
Hi, everybody. As Debbie said, my name is Rihanna. I'm going to begin sharing my screen. I'm going to say that uh, can everybody see my screen in just a second here? Okay, does that seem to be working for everybody? Okay, awesome. So as Debbie was saying, my name is Rihanna. I'm a licensed professional counselor here in Arizona, and I specialize in maternal mental health. I want to give my biggest gratitude to Aurora for hosting this today and for allowing me to talk about this. This topic is something I'm extremely passionate about. As with all of us in the mental health field, typically, we have a reason for getting into this field. I certainly had a reason for getting into maternal mental health as I saw uh, two close family members and friends that were significantly impacted. So I made it my mission then to do everything I could to help out this population. So thank you for being a part of my passion and letting me speak about this today. So the first, just going to make sure this is working properly. Give me a second. Debbie, can everybody still see a white screen? Looks different for me.
Yes, I see it has a triangle with a green
Okay,
exclamation
yes,
point.
that's right. Okay,
Perfect.
thank you. So I want to begin here and say that today's conversation is going to cover some potentially distressing topics. And these topics are deeply personal for all of us. And as I was just sharing, can evoke really strong emotions for us. And so my intention is to approach these topics with the utmost sensitivity and respect in sharing about them. And please know that if you need to take a break, put me on mute, step away for a minute, I totally understand. Your well-being is important. So here's the objectives of today. So this is the stuff that you need to write down for your CEUs and what we're going to cover. My objective for going over this today is, as with all of us, and which is appropriately so with our code of ethics and things, there's certain populations that sometimes we just don't feel comfortable working with. I have that. We all have those concerns. And so my own objective today is that I hope for those of you out here who maybe don't have much experience or don't have much training in maternal mental health, that today just helps you feel a little bit more comfortable in working with this population. Okay, so I know I use the term maternal mental health. We're going to talk about more specifically perinatal mood and anxiety disorders, or PMADs. You're going to hear me using that term pretty frequently today. So mood disorders are things like depression, bipolar, psychosis, and anxiety. I'm going to kind of lump in generalized anxiety, panic disorder, obsessive compulsive disorder, and PTSD. You may be asking, well, what is perinatal? So that term kind of fits from the moment of conception to 1 year postpartum. So it takes into consideration the changing hormones, whether or not somebody continues to breastfeed, the reemergence of their menstruation, and things like that. The question that always seemed interesting to me is why that definition doesn't necessarily include people taking infertility medications or fertility medications, hormonal treatments, etc. Because as we're going to talk about today, those kind of things make a big impact on how people's moods and mental health are. But this is the definition. I didn't make it. Unfortunately, I can't change it, but this is what the perinatal period is defined as. So first, we're going to talk about some statistics here. So I want to give kind of another warning that perinatal mood and anxiety disorders have been identified in people across the globe, in every age, in every culture, every income level, and every ethnicity. During the presentation today, you are going to hear me use terms like women, men, the more binary or heteronormative terms that are typically utilized because that is what the research is typically included of. So there have been good news is some additional research, especially in the past couple years, that is including other cultures, but unfortunately, it is still very white across the board. So I want to kind of give a note there. This is the one of the most shocking things to me, that although PMADs are common, they are not normal. For those of you who have either had a loved one who's been pregnant or you've been pregnant yourself, you're probably familiar with your doctor screening you for things like gestational diabetes, preeclampsia, um, hypertension, and those things happen somewhere around 6 to 8% of the population of people who are pregnant. Perinatal mood and anxiety disorders happen in about 21%. So it is by far the number one complication of pregnancy. And every year there's about 400,000 infants that are born to mothers who are depressed. It's a shocking statistic in my opinion. Nearly 1,200 women every year die due to complications, and nearly 60,000 people have complications that are nearly fatal. And as you can see on the bottom here, suicide is the leading cause of death in women in the first year postpartum. According to a report that was released by the Arizona Department of Health in 2024 of this, or excuse me, in February of this year, um, the uh, there was a 44% increase in pregnancy-related deaths here in Arizona specifically. Arizona received a report or a score of a C on this national report card, with the overall average being a D. So Arizona has a slightly higher, better grade than other states, and California scored the highest with a B minus. So these scores came from each state looking at like the number of providers, different screening policies that were in place, reimbursement from insurance companies, from Medicaid, things like that. So I want to really highlight here the disparity amongst the different populations. So in a report from 2011 to 2013, there was nearly 2,009 maternal pregnancy related deaths. And 43.5% of those, or excuse me, 43.5 deaths per 100,000 were for live births of Black women. 14.4 deaths per 100,000 live births for women of other ethnic or racial groups, and then 12.7 per 100,000 live births in white women. So you can see the significant impact that this has on women and families of color specifically. So what are some of the risk factors? So they could be genetic, whether you have a family history of mental health conditions, personal history of mental health conditions, anxiety, bipolar disorder, depression, whether you have financial hardship, low or no support, specifically your relationship with your partner, a traumatic pregnancy or delivery can also be part of it. And then some of the new ones that research is showing us recently is if the mother is away from her home country or additionally has challenges breastfeeding. And this is certainly not an exhaustive list. There's other conditions as well or situations that might also be a risk factor. Excuse me. There we go. So last I saw, there's 121 participants in here. So I'm assuming they're not all women or people with uteruses, but let's assume that all 121 people in here are people who have uteruses. That would mean that somewhere around, oh, I'm not very good at math. I'm going to say, what is that? About 20, 25 people have experienced or will experience some kind of complication, perinatal mood and anxiety disorders during their pregnancy. I don't know about you, but that's a pretty high number in my opinion. Where we got that number was this study from 2013 that I have referenced down here that studied 10,000 mothers. And so this study of 10,000 mothers really kind of started to shape mental health care, certainly OBGYNs and the American College of Obstetrics and Gynecology, a bunch of different organizations used this study to start changing some of the standards and guidelines. So of those 21.9% of women in this study, 68.5% of them had a diagnosis of unipolar depression. 66 was major depressive disorder with comorbid anxiety, 22.6 bipolar disorder, and 19.3% of those women also endorsed thoughts of self-harm. Um, and one important note that I'll talk later about as well is that of these women, 1 in 5 who screen positive for depression may also have bipolar disorder. So it's important to do additional screening that we'll, as I said, talk about soon. Physiological changes. There's quite a bit, certainly during pregnancy, but even after, during the process of giving birth, breastfeeding, there's huge hormonal fluctuations that happen, and then brain changes as well. I'm sure many of you who have known people have been pregnant or are mothers within that first year or so will often say that they feel cloudy or have mom brain or pregnancy brain. There's actually a lot of science that shows that there is quite a bit of changes that happen in our brain during this time and within the first few years after pregnancy as well. One of the psychiatrists that I took a training with shared with us that being pregnant, I always have to be cautious how I say this to make sure I'm quoting her correctly, but she said that being pregnant and then giving birth is likened to taking 100 birth control pills per day and then all of a sudden stopping. So the hormonal changes that happen when we're pregnant are likened to taking 100 birth control pills per day. Again, that's pretty shocking in my opinion. I think most of our jaws dropped when we heard that. So neuroscientists have discovered that a woman's brain undergoes significant changes, and that the more her brain changes, typically the closer her attachment is with the baby. So this study specifically speaks to the right hemisphere of our brain, which helps with things like intuition, creativity, daydreaming, our emotions, imagination, and things like that. So here are some of the different hormones that you will experience during pregnancy, the birthing, and then postpartum. Progesterone and estrogen are involved in creating dopamine and serotonin, which are mood stabilizers. Progesterone levels typically decrease about 24 hours after birth, whether there is a baby present or not. And the prolactin levels, which produce breast milk, and then the oxytocin that you see over here in the postpartum column, that's a love hormone. And so it helps with bonding and attachment. And then also cortisol increases with stress and lack of sleep as well. And then, as I was saying, the emotional side of, or excuse me, side effects of the infertility medications. These are obviously not an exhaustive list, but these are just some of the medications that can be used during fertility treatments. So they're all medications that can modify our hormones. So it's not surprising that it's associated with mood changes. Going through fertility treatment itself is an emotionally stressful process. So it's also not surprising that women going through that process are feeling vulnerable and are at an additional risk for those mood changes. And it can be a challenge to know which of these medications or their own personal history can be the underlying condition of the infertility, the mood changes, if it's a co-occurring mental health issue. But for this reason, it's not surprising that the mental health conditions in this population might be underdiagnosed from time to time. Okay, PMADs do not only impact women and mothers. This is a screenshot that I took from the Postpartum Support International Arizona chapter's website. So when a woman is experiencing PMADs, it also impacts her husband, her partner, her children, all of her loved ones. And as this screen shows, that it also impacts the cost of care. Inappropriate medical care can happen. At times, child abuse or neglect can happen. It impacts a woman's career, creating difficulties for employers, and certainly a lack of income for the family as well. This is another statistic that was pretty surprising to me as I was learning more about this. So, 1 in 10 new fathers will experience postpartum depression. So maternal depression increased the risk of paternal depression and was the strongest predictor of paternal depression, even beyond the father's own personal history of depression. The paternal symptoms typically occur around 3 to 6 months postpartum, and possible factors for paternal depression can be things like feeling burdened, new financial changes, financial responsibility, certainly changes in their sleep as well. And the non-gestational parents may experience feelings of jealousy, feeling like they're not being supported, maybe being discriminated by healthcare providers at times, which can also make them at risk for PMADs. And research shows that the anxiety rates for new fathers are somewhere between 2 and 18%, depending on what kind of assessments are used and things like that. So research suggests that anxiety typically actually decreases in the postpartum period for fathers, which I've generally seen in postpartum as well. I think the case from that, this is just my own anecdotal experience, is that our partners are very worried about our health during pregnancy, how we're doing, if we're sleeping well, how our lab work is, if our lab work is off. And so their anxiety, I've seen it often increases during that time and then seems to subside after the baby is born. Here's some assumptions about fatherhood in our own society, that fathers are supposed to be the rock. They're the ones that are holding our hand, they're the babysitters, they don't know what they're doing. There's a lot of negative things that are said about fathers and our partners, and it certainly impacts their risk for uh, the relationship with the mother, for their own mental health as well. Talk about some assumptions of pregnancy. All pregnancies are wanted or planned. We actually know that about 50% of pregnancies are unplanned. And unfortunately, not all pregnancies end in a live baby or a healthy baby, and nor do they end in fulfillment. Assumptions about labor and delivery. Strong women don't need medication. You're going to be able to get through this. Doing it the natural way is the only right way to do that. Going through a C-section, having a planned C-section, that's taking the easy way out. Or people will think that they'll instantly bond with their baby as soon as they see their baby or they hear their baby cry. And another common one is that you'll be able to breastfeed right away. won't be any challenges. Um, and actually, sometimes for women who have C-sections, their milk may not come in for a period of time, which can make that a little bit more difficult as well. Let's talk about some assumptions of being a mother. Being a mother is instinctual. You don't need to take birthing classes or breathing classes or how to change a diaper classes. You don't need any of that. You're just going to figure it out. It's going to come natural to you. Breastfeeding is going to come natural to you. Often what I see in practice is assumptions that mothers have of themselves, that if I was a good enough mom, I wouldn't need to take a break. If I was a good enough mom, I wouldn't feel like I needed more sleep. I would want to engage with my children more. I should be able to take care of my kids. Okay, I'm gonna pause real fast here and see before we get into assessment if there's any questions.
The only question I answered was just about the slides. So I let everybody know that the PDF of the slides will be emailed with the certificates.
Okay,
And I don't see any other questions right now. So awesome.
okay,
Thank
okay. I hope I'm not going too fast, but yes, the slides will be shared for anybody if needed. I will try to slow down just a little bit though as well, because I know this stuff and I can just read through it pretty quickly, so I will try to go through it a little bit slower. So the DSM, the big book that we all use, in 1994 included the specifier with peripartum onset, which is typically the peripartum period is within pregnancy or 4 weeks after birth. So you can see it's slightly different than the perinatal definition there. So what do? How do you diagnose? Well, the good news is you can use, when it comes to depression specifically, you can use the typical major depressive disorder severity, and then whether it's a single episode or recurring episode, you can use that and include the peripartum onset diagnosis, or excuse me, specifier if you'd like. Um, and some differential diagnoses. Again, we'll touch on these in a little bit, but the baby blues, that happen around 60 to 80% of women. That could be one additional differential diagnosis. Also screening for thyroid complications. I put that on there twice. You only need to screen for that once, obviously, and postpartum psychosis as well. If you want to read more about the peripartum onset, that specifier, it is in the DSM on pages 152 and 153, or 186 and 187. So perinatal psychosis, if you are interested in learning more about this is a passion of yours. There's a lot of really interesting research taking place through the Massachusetts General Hospital Women's Center for Women's Mental Health. So hopefully we'll have some additional research that will help us to screen and diagnose that in the future. And then if you are considering a diagnosis, a trauma-related diagnosis for a person, you might want to also consider the health or the diagnosis of the fetus or the infant as a trigger for PTSD. So what are some screening forms that we can use? So for mood disorders, you can use the Edinburgh Postnatal Depression Scale, that's such a handful for me, or the EPDS. The PHQ-9, which probably a lot of us are pretty familiar with, or the mood disorder questionnaire to screen for symptoms of bipolar disorder. And then for anxiety, you can use the perinatal anxiety screening scale. This one's a little bit less common, I think, but certainly is validated for people within the postpartum period. There are certain items on the EPDS that is helpful to identify anxiety, but it's likely that that instrument does not identify women with clinically relevant anxiety. So I would say to go to the EPDS specifically. And just as a quick side note, none of these tools are used specifically to be a diagnostic tool, but more to aid in a diagnosis. So here's a couple example questions of the EPDS that you can see. So it's questions like, I have been able to laugh and see the funny side of things, with responses being as much as I always could, not quite so much now, definitely not so much now, or not at all. And because the EPDS looks over the past 7 days, it's not appropriate to utilize while somebody is still in the hospital or shortly after giving birth, especially situations where there was a traumatic birth or complications from delivery. Those are likely going to be pretty emotional days during the hospital stay, and could be very difficult emotional days as well. So the screening, or excuse me, the scoring for the EPDS, this is the scoring. So you can see a typical score. The cutoff that I generally use is like a 10. I've heard some do a 13. So I would say, using your own clinical judgment, but 10 to 13 is generally um, the cutoff there. There's a few questions on the EPDS that are reversed scores, unlike the PHQ-9, where it's just all the severity and scores, a 4 or something like that. Therefore, it can kind of take the assessor a little bit longer to score it properly. So be mindful of that during scoring. And a 13 or higher is clinically significant depression scores. So the MDQ, the Mood Disorders Questionnaire, it is a self-report questionnaire. And according to a 2015 study, we would miss about 10% of the women with bipolar disorders, which is about 3 out of 34. So that would suggest that there's a pretty good, or excuse me, if we only use the EPDS, that we would miss about 10% of women with a bipolar disorder. So the EPDS is still about 90% accurate, which is very good for a screening tool, but it kind of falls short in terms of diagnostic accuracy for people who may have a history of bipolar disorder or maybe presenting with symptoms of bipolar disorder. So we want to use the MDQ where it's appropriate as well. The PASS, or the Perinatal Anxiety Screening Scale. So this was created by some researchers in Australia, and it's a little bit more sensitive to how anxiety presents in the perinatal time frame, and may be used in a variety of settings, inpatient, outpatient, etc. Over the course of the perinatal period, the different levels of anxiety the woman may experience may vary depending on the circumstances related to her own pregnancy. So the 4 subscales that's mentioned here are the acute anxiety and adjustment, general worry and specific fears, perfectionism, control and trauma, and then social anxiety. This particular screening questionnaire does a pretty good job of breaking those down, but it also helps to identify panic, OCD, generalized anxiety, or maybe trauma-related anxiety as well. And as opposed to the PHQ-9, this looks at symptoms in the past month, with the cutoff score being a 26. So anything higher than 26 is usually recommended for, or excuse me, is typical of a anxiety disorder. So when should we screen? According to the American College of Obstetricians and Gynecologists, this is the typical time frame. So during the prenatal visit, during the pediatrician, primary care, um, these are all the appointments that the mother should be screened for specifically. And typically you will see the EPDS utilized in those appointments. So these are again, the current standards that providers should be screening for bipolar disorder as well, at least before initiating any kind of pharmacotherapy for anxiety or depression, if that's not already done. And then one quick side note on here, low-income families may not receive regular prenatal care, and so therefore inpatient providers should also be screening as well. So again, why do we screen? Well, because it's pretty prevalent. It also reduces the risk of symptoms continuing, helps to reduce the stigma, and most importantly, treatment is available. Is this pregnancy or is this depression? Oftentimes the two can kind of look pretty similar. With depression, the person's mood is going to be more gloom, irritable, maybe towards rage. With pregnancy, the mood is going to be pretty labile. It's going to change, be teary, but for the most part, she's going to be able to experience joy and anticipation. Sleep can be impacted during pregnancy and depression as well. But generally for women who are just experiencing pregnancy and not depression, they're able to fall asleep a little bit easier. The self-esteem is typically unchanged during pregnancy. For people experiencing depression, they may experience a lot of shame or guilt. And energy, fatigue can be obviously one of the signs of depression that also can look very similar during pregnancy, but typically a woman is able to restore herself with sleep or rest. Postpartum depression or the baby blues. So as I was saying, the baby blues affect about 60 to 80% of women, again, depending on cultural, on how they're screened. But the hormonal fluctuation is likely the biggest cause, in addition to the sleep deprivation that happens. The baby blues can last somewhere between 2 days to 2 weeks, but it typically peaks around 3 to 5 days after delivery. So as you can see, some of them are pretty common, or I should say similar here. With postpartum depression, there's a loss of interest or anhedonia, lots of feelings of guilt. The mood is primarily unhappy, whereas with baby blues, there tends to be still some feelings of joy and happiness that come through. Perinatal anxiety appears very much like typical anxiety as it relates to the typical presentation for generalized anxiety disorder. If all of you are familiar with the characteristics or the criteria of that diagnosis. So typical coping skills and worries and things like that are often the same, excuse me. But with perinatal anxiety, the excessive anxiety that you see in like generalized anxiety often tends to be about their health or the health of the baby. Trouble controlling worry is often ruminating thoughts. And then the sleep disturbance is checking on the baby, checking to see if the baby fell asleep, if the baby's breathing, if the baby's doing okay, if they're crying, if they're cooing. So perinatal obsessive and compulsive disorder, OCD. This is one of the most misunderstood and misdiagnosed of the perinatal disorders. It's estimated that as many as 11% of new mothers will experience obsessions, compulsions, avoidance, and a feeling of horror about what they're experiencing. So these mothers know that their thoughts are bizarre and are very unlikely to act on them. But it's important as providers for us to understand and to educate our clients what they're experiencing, and that scary thoughts do not always equate to action. It's important to ask about, are you experiencing scary thoughts or unusual thoughts? Because OCD is very often misdiagnosed as psychosis. And so we all have some kind of intrusive thoughts. But people with OCD will wonder why they have those types of thoughts. Let's see. In a 2020 study, some authors speculated that mid-pregnancy anxiety was a marker for postpartum anxiety and OCD. So sleep is a very important for all of us, but especially during the postpartum period. And rates of OCD are somewhere between 7 to 11% across the perinatal period, with the peak prevalence being at about 8 weeks. The one thing I wanted to highlight on here are the what ifs. So that is pretty typical for perinatal OCD. What if my baby has this? What if I'm walking down the steps and I trip with my baby in my arms? What if I go to the store and there's somebody sick who coughs on my baby? What if this and this and this? That is very typical with perinatal OCD, where it's not typical with psychosis. So again, listen for the what ifs. A person who recognizes their thoughts as unhealthy is very likely going to be somebody who's experiencing OCD or anxiety versus psychosis. If they're having extreme anxiety, they feel like they're such a bad person, they're worried about doing something, they're worried about acting on their thoughts. That is much more typical of a OCD presentation versus psychosis. Whereas psychosis, person's not going to recognize that their thoughts are unhealthy or may cause harm. And they might have little insight about how distorted their thoughts are as well. So listen for the what if. That's what I always try to tell myself. So these are typical things that are a low risk. OCD thoughts of harming babies that are a low risk, where a parent does not want to harm their baby. Their thoughts are obsessive, but they're frightening to them. Why am I feeling this way? What's wrong with me? What happened to me? Their parent often goes to sometimes extreme steps to take care of their baby, to the fact that I've had women who've had upstairs bathrooms or bedrooms, and they won't take their baby upstairs. They won't shower for days on end because they don't want to drop the baby or hurt the baby going up the steps. Or parents who don't use certain utensils because they're worried about them flying off the counter and hurting the baby. And parents have no delusions or hallucinations related to harming the baby themselves. So these are higher risk. So specifically the egosyntonic refers to thoughts, behaviors, impulses, or feelings that are in harmony with the type of thoughts. And they're typically acceptable to the individual and their self-image. They're perceived as natural, appropriate. They tend to be very consistent with their goals, values, and beliefs. So egosyntonic is things like they're very comfortable with their thought. They're not worried about why they're thinking the way that they are. Their behaviors they don't seem to experience any distress from the behaviors or the thoughts that they're experiencing. They have a total lack of awareness that their thoughts are maladaptive or problematic. And moreover, they're resistant to any kind of change or treatment or feedback about how they're behaving or what kind of thoughts they're having. So individuals like that are less likely to receive help because they perceive these as beneficial parts of their personality. I know this is important topic, so I'm checking to see a chat there.
The one only question I saw, at least here, is there a recommendation for screeners in the hospital? The current birthing center I work at requires the EPDS within 6 hours of delivery.
Okay, so I just joined, I think 2 weeks ago, a grand rounds at the Massachusetts General Hospital, the Women's Center for Maternal Mental Health, where they talked about this exact thing. And I kind of stole some of their verbiage and used during this presentation today, because this is apparently happening quite frequently in inpatient units. There are certain policies and things like that that obviously you're going to have to go with. But what I would say when you're scoring that, obviously you want to likely play an advocacy role, maybe talk to the higher ups, talk to the doctors, talk to the people in charge to see if they might be willing to reconsider whether the EPDS is used or another tool is used, maybe even just the PHQ-2. But what I would say is, although that might not be the best time frame to use the EPDS, especially that frequently or that soon after giving birth, you can still look at those as a clinician yourself. You can still look at those responses and see if there's anything that seems to be concerning to you. Certainly, if their score is already past 13 in that time frame, that would be an indication that maybe something else kind of needs to be looked into. Um, and I think that's the kind of the safest general answer that I can give at that time. I would say, again, maybe the providers at the hospital could benefit from using a different screening, although I understand how policies and procedures and things like that work, so that may not happen immediately. I would say, just as a clinician, to look at the scores and maybe talk with the person there and say, it says here you're not as happy as you were feeling. Tell me a little bit more about that. What are you not happy with? Did something not go as planned? Um, Oftentimes women will come to the hospital wanting to have every step of it. They have the robe, they have the hair ties, they have the underwear, they have the baby clothes, they have everything. And sometimes just the smallest thing that may not go as they planned can be upsetting to them. Maybe not always to the point of depression, to the point of thoughts of self-harm, but certainly can be upsetting. So hopefully, even though that tool may not be the most appropriate tool during that time, it could still be something that gives you some additional clinical discussion. Awesome question. Great question. Thank you. Come on here. Okay. So, perinatal psychosis is a medical emergency. And as clinicians, we are also mandated reporters. So, I understand we've talked about this for maybe 5 minutes. We've talked about it on 2 PowerPoint slides. So, please do not take the information on 2 PowerPoint slides to be more relevant than your clinical judgment when it comes to, is this person experiencing psychosis or OCD, anxiety? I'm hoping that the information presented today will make you more comfortable with assessing this, but understanding what psychosis can look like in the perinatal period. So again, don't take this to be more important than your clinical judgment, your clinical reasoning, but allow this information to factor into your clinical judgment. Treatment, I don't think there's any other questions. I'll just take a quick, gave birth just past April, actually honor and Bellevue. It's strange. Yeah, there's a lot of hospitals that you still use the EPDS. It is kind of strange. And I think, especially while you're in the hospital, I think a lot of women are fearful to kind of say how they're feeling during that time frame, because you're already emotional, whether your experience was positive or not. You're emotional. And then you're thinking, gosh, what if I don't want to tell them that I'm already sad. I'm supposed to be so happy right now. It's supposed to be the best time of my life. And so if somebody thinks I'm sad, are they going to take my baby away? Are they going to keep me here in the hospital and keep me away from my baby? So there's a lot of hesitancy in using in scoring accuracy, I should say, as a person taking the EPDS. So thank you for sharing that information. Come on, computer, here we go. Okay. So one of the places that I took some training from was a woman named Karen Kleiman. Just saying her name brings me such joy talking about her. I absolutely love her and the impact that her work has done on the maternal mental health field. If you're interested in learning about her more, you can Google her or go to the postpartum stress for Instagram page. Instagram page. But these two posts that she had on her Instagram, I think perfectly sums up what her therapy and type of treatment is all about. This first picture specifically is why I love utilizing telehealth for perinatal women. I get to see the condition of the home. I get to see what she's really looking like. I get to see the messy hair up, the dirty clothes with the spit up. I get to see sometimes the interactions with the partners, the husbands, the other children. But women who are not doing well, as this first sentence here, are very good at hiding it. Um, We come dressed to the nines. We have heels on, we have lipstick, we have our hair done, we have our nails done, we have jewelry, we have our expensive bag. And that door shuts when we're finally in the therapist's office, and then that's when the tears come. Women are very good at hiding this because my own thoughts, likely the societal impact, family impact, etc. We don't want people to know we're not holding it all together. But again, this is why I really, really, really love using telehealth with perinatal women. So women in general during this time frame, because we look really good sometimes, can be overlooked. She doesn't look sick. She doesn't look sick enough. I never would have known she was experiencing that. So after dealing with too many professionals who misinterpret or ignore her signs, she's going to stop seeking help. She's going to be less inclined to disclose how she's truly feeling if she doesn't think that the providers know what she's experiencing or experienced with what she is going through. The most powerful thing you can do, the most powerful thing you can do is to just be there for a woman. This is scary stuff. It can be scary. A lot of us have experienced this on our own, but just being visible there with her can be the most powerful thing that you can do. Whether you're a clinician, whether you're a provider, you're OBGYN, you're a friend, a cousin, a neighbor, just being there and listening to her can be the most powerful thing. I love this picture. So what a cute baby. How are you doing? Across the spectrum, healthcare providers, especially since that study of 10,000 women, and obviously additional studies, but healthcare providers are really starting to focus more on the health of the mother rather than just the health of the baby. So that looks like no longer just weighing the risk to the fetus when utilizing certain treatment interventions. It's also considering the risk to the mom that her not being well may present to the fetus or to the baby as well. One of the common statements that I learned during the trainings that I've taken is a happy and healthy mom is a happy and healthy baby. So this picture here is kind of a nod back to the screen where it shows the different times that a screening is done during the prenatal visits, done pretty frequently. During the infant visits, done pretty frequently. During the postpartum visit, it's once. But that woman is going to be in that postpartum period for a year, or the perinatal period, excuse me, for a year. And I'm really hopeful that as we continue to talk about this and understand this, that we can start shifting our culture and our society to be more focusing on the health of the woman and not just the baby. The baby's important, don't get me wrong. I love babies. We need to focus on them and take care of them, but we also need to start considering the mothers, I think. Um, so as therapists, we often are uncomfortable in working with populations that we're not trained in. Speaking for myself, I imagine that's something that a lot of people are familiar with. So again, I'm really hopeful today that some of the information in here helps you to feel a little bit more comfortable with the clients who may be presenting with postpartum depression or postpartum anxiety. And even if you feel you walk away from today and you feel like I still don't know what the heck I'm doing, I still feel like I need help. Babies and mothers have the same needs. And if you can help that mom to know that she is safe, that she's wanted, that she belongs, that she's welcome, that's going to be transformative. It's often so much you go to the hospital, you see the baby, hold the baby, and we're ignoring the mom. It happens almost immediately. So paying attention to the mom. And again, I'm speaking to clinicians and to, friends and sisters and things like that, seeing how the mom is doing, asking questions like this, or questions kind of evoke whether or not she's feeling safe and protected and heard. So these are some questions that you as clinicians can maybe add to your intake that you can ask throughout your routine appointments. Or again, these can be used for our friends, people in our personal life as well. How do you handle getting unwanted advice? Because let me tell you, as women, they're going to get it. Oh, you're bathing your baby in the tub rather than in the sink, or you're not brushing their hair, or you're not breastfeeding. They're going to get unwanted advice all the time. How are you taking that? How are you eating and sleeping? How are you feeling physically? And perhaps that's only a question that may not be appropriate, 6 months down the road all the time, but especially in the first couple weeks, how are you feeling? What's it like to go through recovery of pregnancy and giving birth? And this center one on here, are you having any thoughts that seem odd, bizarre, or scary to you? Usually when I ask that, especially like in intakes with new folks, or ask a version of that type of question, people will say, well, I'm not thinking of harming myself or harming my baby, anything like that, but it just seems weird to me that I have so much anxiety. So you might see people saying, oh gosh, no, I'm not having any of those kind of thoughts. And then it's pretty helpful way to screen for if she's having thoughts of hurting herself or hurting her baby, because she'll say, oh my gosh, no, 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 no. So that's a very important question, in my opinion, to ask. Here's some additional questions. What's your baby's temperament? What's it like to feed your baby? If your baby slept for a few hours, would you be able to sleep? Or are you going to be up trying to vacuum and clean the house and, put dishes away and things like that? Um, One side note that I'm thinking of as I'm kind of going through some of these questions and thinking of some of the women that I've worked with is oftentimes parents or a particular parent will have their own set of boundaries or kind of rules or things that they're expecting, whether they're during the time frame that they're in the hospital or when they come home, meaning like we don't want anybody to visit us in the hospital. We only want visitors, on the second day or after the first week or something like that. But they're likely gonna feel pretty uncomfortable bringing that up. Um, they don't want to be mean. They don't want to be rude. They know that their parents, their friends, and family are going to want to see the baby. And so they're going to have a hard time saying, I don't want to keep my mom from my baby. I don't want to keep my sister from the baby. But they might be wanting to just have some time with the baby themselves. So another question that you could ask is there anything that you want us to do? Do you want us to stay away from the hospital? Do you want us to be there? Do you want us to only come in the morning? Something like that. So there's some additional questions you can ask as well. And I think I have one more slide. Yeah. Um, let's see here. So feeling intense uneasiness can hit pretty quickly and often with no warning. So they may feel pretty foggy. Um, the scary thoughts may not go away for a while. They might have a hard time kind of catching up with their work, feeling behind in their life. So stressful events could be, I've got to return to work in a week, or I've got to return to work in a month and I don't want to, or I'm not sure if my partner knows how I'm doing, but I don't want him to think I'm scared of being with the baby. So there's variations of ways that you can ask these questions that still kind of get to the main point here as well. Let's see here. Okay, so assessing for intrusive thoughts. Intrusive thoughts can look like I want to go to the park with my baby because I'm so weak that anybody could overtake me right now and just kidnap my baby. Um, or uh, I'm trying to think of another example. Whereas suicidal thoughts are more, I could do this, I could harm the baby this way, I could make all these problems go away with doing this. So again, it's the ego dystonic things that they are not, they don't believe, that they don't feel was within their character, versus egocentric thoughts, behaviors, actions that they're pretty comfortable with. I want to check on the chat real fast again.
There's
Okay.
one question. Let's see. Well, there was a comment, whatever screening I took after giving birth, did not screen for PPG. However, 3 days later, my symptoms increased immensely. I would have liked to have had the screening done some days later.
Mm-hmm.
And then a question, how do you handle women who have had a premature birth and the baby has to stay in the hospital for an extended period of time?
How do I handle women? I'm taking that means like what kind of questions might I ask? How might I treat a woman on the outpatient side. That's my experience. I don't have the experience of working with women in the inpatient side, so I can kind of only speak to that. But I would probably just ask, what is it like to be separated from your baby when you thought you were going to be with your baby? I might try to get a sense of where her mind is at so that I'm not feeding any things to her that could cause anxiety to her as well. I'm going to ask about how our baby's doing. I'm going to maybe, if she's comfortable, ask to share a picture. Maybe she might feel more comfortable talking about the baby and talking about the health of the baby if she shows me a picture, and I'm assuming that maybe the baby has monitors or is in a a special unit or something like that. So finding little ways to assess how the mom is doing, because everybody's situation is going to be completely unique. Even though there may be 10 babies at the NICU at any one particular time, each of the parents and each of the moms are going to experience completely different things. So I hope if that person that has that specific question would want to chime in and see if there's any other way I could answer that, I hope that kind of answers it. Okay, so some things that you might hear moms say or do that might kind of signal in your mind that maybe she's not feeling that well. I don't feel connected to the baby. I didn't think it was going to be like this. I don't feel like myself. Um, Gosh, I just have the worst headache and it won't go away. I've had this headache for days. So you're going to hear, especially if this is a person that you know pretty well, you're going to hear her saying things that just don't seem like herself. That's the biggest takeaway, if I can say from this, that she's going to say she doesn't seem like herself, and you're going to see that she doesn't seem like herself as well. Some common goals in therapy. Obviously, the more broad the depression, anxiety, but more specifically can be, I feel like my husband and I aren't talking, we're not as connected. We have problems with communication. Maybe for people who've had a traumatic birth, or perhaps not come home with their baby, resolving the loss, the grief, certainly attachment concerns can come up, checking their expectations versus reality. And then their idea of, thought I was going to be the perfect mom. I thought everything was going to go the way I had planned. And then complications happened. Maybe the baby's temperament, maybe the baby had to stay in the NICU for a longer period of time. Treatment intervention. So this is just a very broad, this is not exhaustive. There's certainly additional ones that are appropriate to utilize as clinicians with our clients. These are just the ones that I'm personally familiar with. So quick note, EMDR is safe during pregnancy. Over and over and over, research has shown us that. As with any intervention, though, it's not just a simple yes and move forward. There are other things to take into consideration. Um, I've unfortunately worked with a woman who was in the midst of a lawsuit against the OBGYN. And so there's questions of whether or not MDR would be appropriate because there's a pending lawsuit. Whether there's medications, the overall timing of the intervention. So EMDR overall, yes, safe, but certainly as for EMDR clinicians, out there, there's more of assessment that needs to happen. So CBT, exposure and response prevention, and internal family systems, attachment focused therapies are all appropriate to use. And again, these are just the ones that I'm specifically familiar with. So CBT can be obviously helping the client to notice her automatic thoughts and the impact that they have on her. I ask often with the women that I'm working with, what's the evidence that it's going to happen? And okay, all right, let's play devil's advocate. Let's say that that does happen. What's the best thing that would happen? What's the worst thing? What's the most realistic thing? That question seems to get a lot of people really their wheels turning in a good way. Um, Exposure and response prevention, before you even go through the whole treatment modality there, even just asking, what's the feared outcome? What do you worry would happen if you did drop your baby from the steps? what do you worry would happen if you took your baby to the park? And then walking through that and doing the exposure ladder, where maybe somebody just says, I don't want to be alone with my baby. I'm worried that they're going to cry. And I'm in Target and there's a bunch of women there and they're going to judge me because my baby's crying. And so doing an exposure ladder to that, and I should explain exposure ladder is kind of like, okay, if the ultimate fear that you have is the biggest concern you have is other women in Target judging you for not being a good enough mom, um, how can we start to expose you to that in small ways? Maybe sometimes, again, I meet with women through telehealth. I'm showing them a picture of a baby crying and I'm seeing how they respond to that. I'm showing them a video of a baby crying. So, kind of going up the ladder to the most feared outcome that she has. Inference-based cognitive behavioral therapy. So this really focuses on resolving the doubts, so that you no longer feel the need to do the compulsions. And this is specifically, I'm talking about the ICBT for anxiety and OCD specifically. But OCD begins with a doubt. It begins with a fear and then leads to a sequence. So if you didn't experience the doubt, you would stand firmly kind of grounded in reality, not here and now where you're at. So you wouldn't get to feel anxious and then be forced to do that compulsion. So this type of therapy is really helpful for kind of breaking that down, asking questions like, why do you trust your senses in this situation, but not in this one? And the stories that we tell ourselves, these are that we all tell ourselves, um, are really important in focusing on our experience, on what we believe in, and what feels safe or right to us. But in the same manner, um, our obsessional thoughts and ideas can also appear very real to us. So, ICBT can help with these types of concerns. DBT, love my DBT for women as well. The house skills, doing things one mindfully. We all know we live in a very busy world. We're always trying to do two things at once, 10 things at once, driving, talking on the phone, etc. So one mindfully, just sit with your baby. Just uh, do the dishes. Just take a shower. Don't try to also be listening to a podcast about how to be a better mom or um, breastfeeding and cleaning the pumps or all these things that we all try to do, just one thing at a time. Try to think of using non-judgmental thoughts about yourself. Um, Emotion regulation skills can be like, okay, you're feeling really angry. You say you're experiencing mom rage. What is that telling you? What do you think is going on in your environment that your body's telling you that you need, that you're experiencing this? Um, what is your emotion? What is your rage communicating to your husband, to your partner, to your coworkers? And then checking the facts. What is the emotion that you want to change? What is the prompting event? What is it that happened that made you feel this way? What are your thoughts? What are your interpretations about that? Um, are you assuming a threat here? Is this something that you see as a threat to yourself, your way of life, your baby? And then the dear man skills and the radical acceptance as well. Radical acceptance, something I'm always trying to practice as well, encouraging my clients of all the bajillion of ways that our world could go. This is how it is. I don't like it any more than you do. I know you wanted to have a different birthing experience. I know you wanted your doctor to listen to you. I know you wanted your husband to be there, whatever it might be. But this is the way it is. We're not saying we want more of this. We don't want more of this complication. We want things to calm down, but we can't go back. And so radical acceptance can be a very transformative practice for women. Interpersonal psychotherapy. So this is helpful for the grieving process specifically, asking the women, what do you feel like you lost? And sometimes, it's their baby, it's a relationship, it's maybe they've left their job so they can be a stay-at-home mom, but they're missing that part of day-to-day life where they got to talk to adults or have conversations. And so asking, what have you lost? Is it the identity? Is what you thought you were going to have? What kind of changes happen in your life? Who are you now that you're a mom? Like, what did you think you were going to have, and what do you actually have? And then sometimes this type of therapy can be more or better suited for couples counseling as well. So for the LMFTs out there, you're probably pretty familiar with this, I imagine, but this is a newer type of therapy to me. So I'm interested to learn more if anybody in the group wants to speak to how they might utilize this. And then obviously the attachment therapy can also be helpful with the grieving process, exploring the different conflicts they have with the changes that they may or may not have been experiencing, and creating new supports for them as well. I'm going to check in on the chat again real fast. I think we're good there. Okay. Okay. Speaking to Karen Kleiman, who I mentioned earlier, she kind of got me onto Donald Winnicott. So I added this, the next two slides, I think is a kind of a last minute thing that I thought might be helpful. Donald Winnicott proposed that an infant cannot exist separately from the mom, that they are only two and they're a state of oneness, or they're only themselves, but they're a state of oneness between them. The mother is attuned to the infant's needs and creating an environment where the child is taken care of and can thrive. So he introduced this concept of the good enough mother, that perfection is not required, and that the mother should be good enough or provide good enough care where occasional frustrations are normal and beneficial for development. So this might look like for perinatal folks, might look like, well, I can't go take a shower because even if I put the baby in the carrier outside, he's going to cry the entire time. That's okay. You need to take a shower. You need to be able to take care of yourself. You need to be able to eat more than just, the last few pieces of chicken nuggets or something like that. So it's okay to have everything that's not perfect. It also, this idea of the good enough mother helps with role frustration because she's being able to be herself and live her life and feeling more like herself. And it helps to, let's see here, the objects like teddy bears that can be helpful for infants to transition. Um, I feel like I'm going over this pretty quickly. So let me read. I said this is something I added last minute. Let me think there's anything else I should, oops, I apologize that I should add to this. I don't think so. I'm blanking a little bit too, I admit. Okay, so the division of labor. Again, this is probably one of the biggest things that I see in practice recently. I feel like I'm doing it all. My husband's here. He's super supportive. He always tells me I need to rest. He always tells me that he'll need to help me out, but I'm doing it all. And so I'll have a conversation. I kind of, again, just jotted these things down is I'll say to the women, what did this look like prior to you guys being pregnant, having kids? Oftentimes with women, we are, when we first move in with our partners, oh, I'll take care of that for you. I'll iron your clothes. I'll do your laundry because that's how we showed that we love them. And so that standard can carry over to when kids are involved as well. And then the women can often feel just completely run down because she's got too much on her plate. So I'll ask, what did it look like prior to the baby? Um, I often encourage women to work on the language that they're using with their partners. I've received comments from people, from my partners saying, it feels like I'm coming at them rather than coming to them with a conversation. So how I approach what my facial, my body languages can all be a part of that as well. And I'll ask things like, how does taking all this on help you, or not getting his help make you feel? Often the women don't even have a place where they can say, you know what, it takes me off. Feel like I'm doing everything around here. And just voicing that, as you all are aware, just voicing and being able to vent about this can help them to be like, you know what, maybe I just need to talk to them. It's probably just as simple as that. So asking women like, do you have a voice? Why or why not? This can kind of assess for if there's maybe any intimate partner violence, maybe just a tense relationship. Can also assess for cultural changes. Sometimes women will say, this is just how we were raised. Women take care of everything, and I can't go against that. That's what he was raised with too. So I can kind of assess for that as well. And then also, are you asking him to get the milk, or are you asking him for actually what you need? I might say, hey, honey, can you pick up the milk on the way home? But what I'm actually asking is, I have been doing everything today while you've been gone. All I need you to do is come home and get one thing so I can make the dinner. So if I said that in a different way, I might actually communicate how I'm feeling. So going back to the chat, nothing. Okay. So again, this is how I show my love, taking care of all the things around the house. Yeah. Okay, so this is what wraparound services can look like. Help with the baby can look like a doula, can look like a night nurse, can look like a neighbor staying with the baby, having in-laws or parents come by, having time for herself. It could be like, you know what, I'm going to take the baby, you go shower. I'm going to take the baby, why don't you go to Starbucks? Why don't you call one of your friends and go see a movie? Medication can be a role, good nutrition, proper sleep. Can't highlight that one enough. Super important. Talk therapy, and then social support and groups. Additional resources and information. So I'm not sure if we have any like nurse practitioners, doctors on here, but here in Arizona, we have the Arizona Perinatal Psychiatry Access Line. So if there is any prescribers in Arizona, you can call this number to get a consultation with a provider at the Arizona College of Medicine, University of Arizona College of Medicine, to say, hey, I have a perinatal client considering, this medication, and talk to a psychiatrist who specializes in perinatal mental health. And I saw that there's a couple folks who joined, I think it was from Maryland, the Postpartum Support International. If you go on their page, they also have information for a more national psychiatry access line as well. So again, this is for providers only. It's not for therapists, for master's level clinicians, or patients themselves to call, but can be helpful for providers. The National Maternal Mental Health Hotline. So you can Google this as well, but this is a 24-hour crisis hotline for women, parents, to call if they need help any time of the day, any time of the year. And then Postpartum Support International also has a hotline. It is not a crisis hotline, but certainly a hotline to call and to give to your friends, to give to your clients, your patients, etc., that they can look for resources for maternal mental health specialists, for support groups, etc. This is all in the slides that will be sent out as well. Here's some additional podcasts. The Birthful one I really like. Mama Thrive Village, The Good Enough Mother. So there's a couple mothers, a couple podcasts here that might be worth to explore if you're interested or could share with your friends or patients. A couple of books I really like, highlighting again on the lower right there, The Art of Holy in Therapy, Karen Kleiman. She's also the author of The Good Moms Have Scary Thoughts. And the perinatal patient is a woman, Hillary Waller, who worked with Karen Kleiman, or still works with Karen Kleiman. So their books are extremely helpful. The Matrescence, the Lucy Jones, the one in the upper right left-hand corner, is a very interesting, just like adolescence, matrescence is this, I don't want to say new, this idea has been around for quite some time, but very interesting read. The MGH Center for Women's Mental Health, there's their website there. The Postpartum Psychosis Project that I mentioned is going to be listed in these slides as well. They're who hosts the Grand Rounds that I was talking to you about. Very helpful. I really appreciate going to that. Oh, this isn't showing up. Oh, there we go. So this is a show, or excuse me, a documentary on Hulu called Aftershock, that speaks to the wide disparity in maternal mental health care, maternal mortality, specifically in people of color. Um, so this was a very impactful video if you're interested in learning about it and have a Hulu subscription. Postpartum Support International, again, can't thank them enough for what they've done for our society, our country, getting information out there. So postpartum.net is where you can learn more information. And then the support groups that I was mentioning, if you go on their page and go to, I think it's, if I remember correctly, it's Get Help, and then it's going to say all the different support groups. They started a couple years ago with about 10 or so support groups. I could be wrong on that, but they've added just a ton and ton and ton. So for different populations, there's a dad support group. There's a uh, support for military moms. There's grandparents ones. So there's one for a good chunk of folks out there. These are totally free, 100% for free. The challenge can be that sometimes the groups are full, or maybe they don't fit into schedules sometimes for folks. But here's why I recommend them to everybody. Not only are they free, but when you join, you can be totally anonymous. Oftentimes, the complication that I hear from support groups or people are saying, no, 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 I don't want people to know about me. I want people to know about my problems, but you can remain completely anonymous. So when you go on the PSI website and say, I want to go to the birth trauma support group, you have to register there, and then typically somebody calls you, kind of screens you a little bit, again, making sure that you're appropriate for that group, but then also screening out any lurkers. And then when you join, you can keep your camera off, you can change your name so nobody knows my name is Rihanna Schmidt and I'm joining a perinatal psychosis group. And I really, really encourage people to add this to their list of supports. Okay, so here's just some of my references, and then some resources that I have on my website as well. These are free for everybody. And then lastly, my information. So you can reach out to me if any questions. I'm more than happy to talk. Again, this is my passion. I have a reason for doing this. So thank you so much for letting me talk about this today. And I'm more than willing to exchange emails, exchange texts. If you have questions, if I can send any additional resources, anything like that, please feel free to reach out to me. And I think that was all. So
Awesome. Thank you so much.
you're very welcome.
Just one question. Beyond the interventions mentioned, what kind of specialized training would you recommend for therapists to help treat this population?
Excellent question. Well, if you're interested, the first place I would probably say, I'm gonna stop sharing here just one second. Okay, the first place I'd probably say is to go to Postpartum Support International's website. They have training for clinicians. That's where I got, if you see the letters behind my name, the PMHC is Perinatal Mental Health Clinician Certified. So they offer that training, so that could be a good place to start. They have a ton of other trainings or links to other trainings on their page. Karen Kleiman, again, I absolutely admire her and her training. That could be an additional training that you take. There's some Facebook groups specifically for maternal mental health therapists that might mention additional information. Um, Probably the Postpartum Support International is the number one place I would refer folks to. Any recommendations for individuals studying for the PMHC? If you took the training, follow the guidelines in your book. Follow that book, the manuals and everything that they gave you. I studied that. I did okay. I'm here today to talk about it. So I would say just go by the manual.
It looks like Carrie Martin said Arizona has the Infant Mental Health Coalition, and then that there are trainings through 0 to 3.
Yes, yes, there are those as well. Thank you for mentioning that.
Awesome. Okay, I am going to stop recording.